All right. Well, welcome everyone. I guess we'll get started. My name's Dr. Gerald Pierone. I'm an infectious disease doctor, and I've been in Vero Beach for about 31 years now. I'm also a member of the Mooring, so some of you look very familiar to me. Thanks for coming out today to hear this discussion about COVID-19 and where we're going with this pandemic. What I'm going to be talking about today is the presentation overview. We're going to go through the virology, we're going to talk about the virus, we'll talk about the current state of the pandemic, also diagnostic testing a little bit. We'll talk about means of prevention. There are two main means of prevention, pharmacologic prevention and non-pharmacologic prevention. We'll talk about vaccines, and I think the Delta surge is what we're calling it, what we're going through now with this dramatic increase in cases. We'll talk about that and some of the reasons for that. And we'll talk a little bit about treatment as well, because I still get patients that are referred into us and they said they had COVID, they called their doctor, and their doctor said, oh, there's nothing to do, go home, get an oxygen monitor and see what happens. The truth is that treatment advances are definitely occurring in the world of COVID-19, and we have very effective treatments if they're given at the proper time. And we'll leave plenty of time for questions and answers as well. So my background, I'm an infectious disease doctor. I've been here for about 31 years. And my main interest in medicine, in infectious disease, was really HIV medicine, and I had a circuitous route to get to the world of COVID-19. Our research team was part of an organization called the AIDS Clinical Trials Group, which has been around for 30 years, started by Dr. Anthony Fauci, to do collaborative research on HIV. And this spans back to the era when HIV was a uniformly fatal disease. Now we're at the point where HIV is more like a controllable disease like diabetes. But we've been doing research in the world of HIV for 30 years. When the COVID-19 pandemic hit, the government realized they needed to redeploy some of these assets and resources to do research on COVID-19, and that's where the AIDS Clinical Trials Group came in. So they started a new research program called the ACTIV, ACTIV-2 protocol, which is an adaptive protocol, meaning no treatments available, let's figure something out, we'll do placebo-controlled trials. Once we find something that works, that'll become the standard of care, and then we'll get the next drug, and then the next drug. So the idea is, in a very quick adaptive format, to try to figure out what we can do to save people with COVID-19 as quickly as we can. And that's really what led to the development of monoclonal antibodies, which to this date are really the most effective treatment we have for COVID-19. We're involved with clinical research with remdesivir, which is another antiviral which is used to treat people with COVID-19 if they get sick enough to be in the hospital. In order to do this, we actually set up a separate office, because you can't just have patients with active COVID strolling into your medical practice and treating them because of the risk of cross-contamination, getting your staff infected, getting other patients infected. So we set up a dedicated COVID treatment unit around the corner from the hospital, where patients with active COVID come in from the front door, our staff come in from the back door, we put on our protective gear, we have exam rooms in the middle, and we provide monoclonal antibody treatments or clinical research in those rooms in the middle, and then we exit the same way. So what about the virus? A little bit of terminology. SARS-CoV-2 is the name of the virus that causes COVID-19. Now we use them interchangeably. We talk about COVID-19, that's really the disease caused by SARS-CoV-2. It was first identified in Wuhan, China in December of 2019, and it is transmitted primarily through airborne transmission, droplet transmission. So if you're sitting across from someone, next to someone who has COVID, even if they're asymptomatic, even if they're not coughing, the challenge with this disease is people can transmit SARS-CoV-2 for a day or two before they even develop their first cough or their first fever, which is why this has become a worldwide pandemic. Very different from SARS-CoV-1. Many of you don't remember, but in 2003, there was SARS first hit the scene. Again, it came out of China, and it killed about 8,000 people worldwide. They were able to stop that pandemic in its tracks. Why? Because with that disease, people became symptomatic right away. They would have fever, and so what they did is at the airports, they would have temperature checks. So if you were leaving China, going to Canada to the United States, you had your temperature checked. If you had fever, you were blocked from entering the country, and they were able to interrupt the transmission of that disease, but not the case with SARS-CoV-2, unfortunately. It's highly transmissible even among asymptomatic people, and it's a RNA virus with a relatively high mutation rate, which is kind of why we're in the pickle we're in now with these variants that have been coming out because of this worldwide infection, spread, and transmission. So what about this variant evolution? You hear about it all the time. The initial ancestral variant in Wuhan, China, didn't last very long. It only took about 2 or 3 months before a major mutational change occurred, actually in Italy. And most of the virus that we've seen in the United States was not the original Chinese strain or Chinese variant. It was really the variant that came from Italy. And then about 6 months ago, this strain from the United Kingdom, which is now called Alpha, became the predominant strain. How does that happen? Just, anyone who knows anything about evolution hears about this notion of survival of the fittest. If you have two species competing for a certain environment, the one that is more fit, better able to compete, becomes a dominant species. Viruses do the same thing. This current Delta variant that we're dealing with, when you look at the levels of virus in the nasopharynx of someone with COVID, it's 1,000 times higher than the Alpha, the UK variant. So obviously, if you have 1,000 times more virus in your nose, you're much more likely to transmit it to someone. That's the reason that we've had this huge explosion of cases and this recurrent surge when we thought we were actually out of the woods. We thought by June we were on the other side of this, but not the case because of these variants that have mutated over time. So what about SARS-CoV-2 infection? I would say that the most remarkable thing about this virus is the unpredictability of it. You have children who are asymptomatic. In the beginning, when we first started testing, we would see whole families come in, 4 out of 5 kids would have COVID, they'd be completely well. You would never know they were sick. Young adults don't get as sick, so you can have a mild infection, you can have a moderate infection, or you can have a severe infection. But the real challenge with SARS-CoV-2 and with COVID-19 is that it's an unpredictable second phase, because what happens to some people is they go through the first week of illness, they have a bad flu, they're achy, they're headachy, they're coughing, they're sneezing. We've all been through that. If you're a human, you've had something like that. But then, instead of getting better, around between day 7 and day 10, they get much worse. They notice that they're winded, they're having trouble breathing, they're coughing more, their headache gets worse. Instead of getting better, they start going down the tubes, they go in the wrong direction. What causes that? The current theory is that it's caused by the body's immune system actually responding to the virus in an overly robust immune response that leads to inflammation in the brain, in the kidneys. People are more likely to get blood clots, so you get this whole constellation of what's called cytokine storm. So you can have people that are fine after the first week, they're not that sick, but the second week they get really sick. Those are the people that you're reading about ending up in the hospital emergency room, requiring oxygen, hopefully not ending up on a ventilator. It's that unpredictable second phase that's really the challenge with this disease. It's also one of the things that leads to misinformation, because everybody knows someone who's had COVID. They say, I had COVID, it wasn't that bad. That's true. 80% of people, even 90% of people, never enter that second phase of the illness. They just get a bad virus, they get over it, and life goes on. But it's that 10 to 20%, especially people who are vulnerable, older, immunocompromised. But it's not just them. Every now and then, I have people that are triathlete. They are in really good shape. They don't take any medications, and they still get as sick as they've ever been in their life, and that's the unpredictable nature of this disease. What about testing? Just a little primer. DNA, which we have in all of our cells, which is really the template for life in general, gets transcribed into RNA. This is an RNA virus. And that RNA is then transcribed as a template for production of proteins. So when we have structural proteins and other proteins in our body, they're really related to this template of DNA going to RNA, which then goes to protein. So when we diagnose someone with SARS-CoV-2, we're doing a nasal swab or nasopharyngeal swab, throat culture, saliva testing, and we're looking for either RNA with the PCR, polymerase chain reaction, or we're doing a rapid antigen test, which is looking for the proteins of the virus that are causing the disease. And now, in the beginning, a year and a half ago, when we would send a test, it would take a week or two to get it back from one of the central labs. Now there's much more availability of rapid 15-minute testing, both for RNA testing, the PCR, as well as antigen testing. This is where some of the challenges come in, though. Someone can have an infection with SARS-CoV-2, get infected, they're sick for their 7 or 10 days, they're getting better, but in the risk of contagion, the infectious period of this disease is about 10 days on average, which is why the CDC says that 10 days after people recover, they can get back into circulation. There's that 10-day isolation. But if you do a PCR, if you check that person at day 11, day 12, very often they're still positive. And it's not that they have infectious virus in their nose, they have these fragments or remnants of RNA that may stay there for weeks. And I've even seen some people 2 or 3 months later, they're still a positive PCR test. So in the beginning, you had to get a negative PCR to be able to go back to work. That's no longer the case. We go by that 10-day isolation period. How do we know that? We know it because we do viral cultures. If you take people and you say, can we actually culture virus from this person, basically by 10 days in that 7 to 10 day window, which is when the immune system is kicking in, is when they go virus negative in terms of testing. What about blood testing? Blood testing is where you're looking for previous infection or previous immunization. For example, someone says, you know what, I was really sick 6 weeks ago, I had this terrible viral syndrome, I think I had COVID. Well, if you get their blood and they have antibodies to SARS-CoV-2, then yes, they had COVID. On the other hand, if their antibody test is negative, then they probably didn't. Antibodies don't stick around forever. Someone that gets infected a year ago initially will have high antibody levels in their blood, but every month those levels kind of drift down a bit, and it can eventually get to the point where they're undetectable. Doesn't mean that person is completely unprotected from SARS-CoV-2. There is a degree of natural immunity that occurs when people get infected with this virus. Can they get reinfected? Absolutely. Are people that have recovered from COVID as at risk as people who have never had COVID? Not even close. People that have never had COVID, that have no antibodies, are at great risk of getting infected. In fact, you can make an argument that because of this Delta variant, because of the high infectious or contagious nature of what we're dealing with now, there's really going to be only 3 outcomes for anybody in our country, which is 1, you're either going to get vaccinated, 2, you're going to get COVID, or 3, you're going to live in a log cabin and have no contact with other humans. That's about it. You know, one way or the other, it's going to find you. That's what we're seeing now, which is one of the reasons the hospital's in crisis mode, which is why we're in crisis mode, because it's such a highly contagious virus. Some of the viral experts say this is as contagious as chickenpox. You don't see chickenpox much anymore because the kids get vaccinated, but back in the day, it was just a highly contagious disease that would just race through communities before the vaccine became available. So, and I'll talk about this later. So if somebody is recovered from SARS-CoV-2 and they have antibodies, if they then get a vaccine, they get very high levels of antibodies and their chance of getting reinfected become almost, I wouldn't say almost negligible, but if they do get infected, they're much less likely to have a benign course. And I'll get into that when I get into treatment shortly. So what about the pandemic? Well, I think we all know this, over 600,000 people dead in the United States, 33 million cases. The peak in January, we had almost 4,000 or over 4,000 people dying every day. By June, nationwide, we were down to about 300 people dying every day. And again, it was reflected in our practice too. In the entire month of June, in our monoclonal antibody clinic, we treated 2 patients for the entire month of June. We were all getting excited. 4th of July is coming. We're going to have a great summer. Didn't work out that way. We were then up to 500 deaths a day 2 weeks ago, and this morning it was 1,000 deaths from yesterday. So we're having this second surge, and 99% of the people that are dying now are unvaccinated. So it's a different world. What about prevention? Well, non-pharmacologic. That's what we're doing here. What are we doing? We're all wearing masks. We're socially distancing. We're in a room with a high ceiling to get better airflow. And instead of shaking hands like we used to, we're bumping elbows or bumping fists. We're paying much more attention to hand hygiene and surface decontamination. Out of all of these, surface decontamination is probably the least important, but we were doing a lot of deep cleaning in the early days with the idea being if we can clean all the surfaces, we'll prevent COVID. The truth is it's really transmitted person to person, 99% of the time. So that's really what we need to be focusing on going forward. So what about prevention of SARS-CoV-2? Well, I just mentioned immunity. When you get infected, you do get some degree of immunity. Can you get reinfected? Yes, we see people getting reinfected all the time. Can you get reinfected after getting vaccinated? The answer, if you'd asked me that question 3 months ago, I would say the chance is almost unheard of that we're going to see that. That was before Delta. Now in our monoclonal antibody clinic, 25% of the people we're seeing that we're treating with monoclonal antibodies have been fully vaccinated. So who are these people? They're typically 80 years old or older. I should just say older, typically. They got vaccinated during the first round of vaccines in January, February, and March. When we look at their antibody levels, they're low. They didn't get that greater response to the vaccine. Why? Because if you're 20 years old and you get a vaccine, you have this terrific, great response. If you're 80 years old or 90 years old, your immune system is aging. It doesn't respond as well. So those people are at greater risk. But what I'll tell you is that even those people that get infected or with SARS-CoV-2, despite being fully vaccinated, typically are not that sick. They're sick, but they're not deathly sick. We've had, out of all those patients we've treated, only 2 of them have ended up in the hospital, and both of them survived their hospitalization. On the other hand, the people we're treating, the unvaccinated people we're treating who are much younger, 30 years old, 40 years old, 50 years old, get really sick. They get sicker quicker, and a number of them have died in the hospital after a horrible stay on a ventilator, putting their family and all of their loved ones through that. Does that happen commonly? No. The overall mortality of this disease is still in the 2% range, but think about it. We have 330 million people in the United States. If you have a disease that causes a mortality of 2%, that's a lot of people dying, a lot more than 600,000 people that have already died. So we do have treatments. Monoclonal antibody, I'll talk about in a moment. What we don't have yet, which we desperately need, is a pill. So somebody calls and says, hey, I have COVID. Oh, let me give you, just like we give Tamiflu, a pill to treat influenza. We don't have that yet for SARS-CoV-2. It's being worked on, but we're not there yet. I talked about the Delta surge. How did we know this was going to happen? We really didn't know. We looked at India. In India, this is kind of a summarization of where we were. We thought we were out of the woods. Masks were coming off, travel was picking up, restaurants were opening, and we thought we were out of the woods. But then what happened in India? So we started getting these reports right in that period in June, July in India, people of this incredible surge in India which has a population of 1.4 billion people. When this surge started, only 1% to 2% of Indians had been fully vaccinated, even though India was tasked with producing most of the COVID vaccines for the underdeveloped parts of the world. When they got hit by the Delta surge, they put an immediate halt on vaccine deliveries to the other countries because they wanted to redirect them for domestic use. And over the next month or two, India vaccinated about 450 million people, more than the entire population of the United States. Why did they do that? Because they were desperate. They were in trouble. Their hospitals ran out of beds. They ran out of oxygen. People were dying. Hospitals had people on ventilators, people on oxygen. They would run out of oxygen, and these people would just die like 20 minutes later. It was about as terrible a situation as you can imagine. And the official death rate was 400,000, but people believe it was tenfold higher than that in the real world. And if you remember these images from a couple months ago, because in India, their funeral rites are open air cremation, and they weren't able to keep up with this as well. So the Delta variant was first discovered or first emerged out of India. In May of 2021, less than 1% of infections in the US, but look, by July 31st, over 93% of infections. Now it's well over 95%. It's virtually the only variant we're seeing for the reason I mentioned before, survival of the fittest. This is the fittest, most evil virus we have. 1,000 times more virus in the nose. Younger people are more vulnerable. If you look at the hospitalization rate for children now in the United States, it's the highest it's ever been in the last few weeks. We're starting to even see children who are getting infected ending up in the hospital needing oxygen. So this is a serious disease. There is a decrease in vaccine effectiveness to varying degrees. What do I mean by that? When you look at the vaccines still prevent hospitalization and death by over 95%, but we're definitely seeing these breakthrough infections, but not necessarily the really sick people that we see when people are unvaccinated. So what about locally? What's going on? Over the weekend, or Friday, Cleveland Clinic leadership did a video that talked about how dire things were at the hospital. When you look at early July, 35 patients were in the hospital. This is across the 5 Cleveland Clinic hospitals up and down the coast, down to Martin, Tradition, and then Indian River. 90% of the patients in the hospital with COVID-19 are unvaccinated. In the intensive care units and ventilators, it's more like 98% of the people are unvaccinated. Elective procedures and surgeries have been on hold. I have patients that need their valve replaced, need their colonoscopy, need whatever they need. They're not getting it now. Everything's being put on hold because the hospital's been completely taken over with caring for people with COVID-19. The nurses are burnt out, the doctors are burnt out, they're barely holding it together, so things are bad. And on a scary note, some of these hospitals, many of the hospitals in Florida, only have 2 days of oxygen left. Now, we're not India. I think we're going to be able to get oxygen to those hospitals, but it just shows how tight things are in the state of Florida. And we currently, as of a couple days ago, 107 patients in the hospital with COVID-19, 30 of them in the intensive care unit. What about vaccines? There are 3 vaccines that are approved. They're not experimental just because some people are under that impression. They're approved under what's called the emergency use authorization, meaning that the FDA has approved them, but under emergency use because they don't have 6 months of safety data yet. The expectation is that this week, the FDA is expected to grant full approval for the Pfizer vaccine. Moderna should come shortly thereafter. So we have 3 vaccines, 331 million people in the United States. Unfortunately, or fortunately, 49 people in our country are under 12, so they're not eligible yet to get the vaccines. The hope is that within 2 to 3 months, the approval will be there for children to be able to get vaccinated as well. 167 million people have been fully vaccinated. 59% of eligible population are fully vaccinated, but only just over 50% when you add the children or people not eligible into that equation. So we're nowhere near this idea of herd immunity. But also, by the same token, if something triple horrible was happening with vaccines, we would know about it because over 300 million of them have been given in our country and well over 1 billion worldwide. So we do know the side effect profile of these vaccines. What about locally? Indian River County does a little bit better than St. Lucie County. About 84% of our patients over age 65 are vaccinated compared to 73 in St. Lucie, and 78 in Brevard. So obviously people that are older realize they're at greater risk. They have much more vaccine enthusiasm, younger people more vaccine hesitancy. So what are the reasons for vaccination? As a doctor, it's not that uncommon that people goes, oh my gosh, doc, I have never been so sick in my life. So I've been practicing medicine for 30 years. You hear that occasionally, but I've never heard that from more people in the last year than I've heard with SARS-CoV-2. And I'm not talking about old, frail people. I'm talking about young, healthy people that, again, are marathoners. They're healthy. They don't take any medications, but they are as miserable as you can imagine. 99% of the deaths are occurring in unvaccinated people. That's pretty darn compelling evidence. If you were a drug company, you came out with a drug and said, look, 99% of people that take this drug aren't going to die from this, you would either win the Nobel Prize or make billions of dollars, probably both. But we have a vaccine that does this, and it's not being utilized to the full extent that it should be. I already mentioned that our healthcare systems are overwhelmed. I mean, there's not an infinite capacity for nurses and doctors. If you have a heart attack, if you need a ventilator, whatever you need, it's going to be tougher and tougher to access that care unless we turn this around. I mentioned before, people are being turned away from the healthcare setting. Plus, there are people who just are not eligible or don't respond to vaccines. There are some people that have had a bone marrow transplant. Vaccines don't work for them. They can still get sick even if they try to get vaccinated. And overall, but the bottom line is the risk of vaccine is so infinitely lower than the risk of getting SARS-CoV-2 that it's a very easy decision, because everything we do in medicine, everything we do in life is that balance, that risk-benefit balance that we do, and it's particularly true in this situation. Vaccines, as we know, don't completely prevent infection, but they certainly lessen the severity. The average 85-year-old who's fully vaccinated is about as sick as the average 50-year-old who's not vaccinated. And they're both sick, but the 50-year-old is often sicker. The other thing is that low vaccination rates allow for more viral transmission, hence more development of these resistant variants that are taking over the world. The other reasons for vaccination, our businesses are suffering. Travel, hotels, restaurants, schools, vaccinating, and why is that? Because vaccinated people are increasingly fearful of unvaccinated people. I'm hearing now from people, oh my gosh, I fired my accountant. I got a new accountant, he won't get vaccinated. In my medical practice, we instituted a vaccine mandate. We lost 3 of our long-term staff. They were like family to us. They just, for whatever reason, didn't want to get vaccinated, but before they left, we would have patients in and the patients be like rolling their eyes. Can you believe people don't want to get vaccinated? Here's my assistant, who's one of those people, having to listen to this all day long, people thinking that they're a dunderhead. So it's not fun. They're increasingly fearful. I had an orthopedic surgeon that was getting rehab for a shoulder operation, and he asked the physical therapist, have you been vaccinated? She was like, it's none of your business. And he was like, it is part of my business. Go get a mask. I'll get a mask too, because you're taking care of me. I don't want to end up getting sick on top of recovering from my procedure. So vaccine mandates are coming in some circumstances. Colleges, businesses, clubs, and vaccine passports are already being implemented around the world in different areas. If you want to go to a club, if you want to go to a restaurant, people are going to be looking for vaccine mandates. So it's coming, it's being pressed. So what about medical and vaccine misinformation? I have to say that in the last 6 months, I've heard some of the most fantastical and bizarre explanations of what vaccines do or don't do. So there's a lot of bad information out there. And it's nothing new. This is an advertisement from the 1950s, where Camel cigarettes would enlist doctors, say, most doctors smoke Camels, the cigarette preferred by physicians. Well, think about it. In 2010, 2% of physicians smoke cigarettes regularly. As of last year, it's about 1%. Would you accept medical information from a doctor if they were smoking cigarettes regularly? You would probably look a little bit askance at that information. 96% of physicians have been vaccinated for COVID-19. Now, the 4% that haven't are probably not the ones at the top of their medical school class. And these are some of the doctors that are on social media promoting these bizarre theories, and again, not based in science, not based in evidence, but based in whatever they've come up with on their own. So it's not logical, it's not scientific, but it is misinformation, and we need to push against it. So there's vaccine hesitancy is on a spectrum. In the early days, when vaccines were limited, it was like the Hunger Games. We had all these older people that were kind of pushing to the front to get their vaccines, but most people are in the middle. They're kind of on the fence. I've heard so many times, I'm waiting for full FDA approval before I get this vaccine, and I get that, but we're about to get full FDA approval, and unfortunately, we're already seeing many, many people dying because they were, quote, waiting for full FDA approval to get their vaccine. What are some of the reasons for vaccine hesitancy? Fear of short-term and long-term side effects. Is this going to alter my DNA? No, it's not going to alter your DNA. These messenger RNA vaccines are really a mechanism or a platform to deliver fragments of viral proteins to the immune system to stimulate an immune response. No different than the vaccines we get when we're kids, no different than the vaccines we get for adults to prevent pneumonia and other diseases. There are people that have mistrust of medical system and providers, concerns about fertility. There's absolutely no evidence that these vaccines impact fertility. Where the question comes up, were these vaccines rushed too quickly? What the FDA did, or what the government did actually, is when it was recognized this was an emergency, they told drug companies, we're going to give you, I'm making this number up, $1 billion. Start doing everything as if your vaccine is approved. Make the glass vials, get your processes in place so that if you get approval on day one, you're ready to go. But they still went through all the phases. Phase 1, safety trials. Phase 2, small numbers of people. Phase 3, larger numbers. So all of those steps were done. They were done in a truncated manner because of the emergency situation. And the other main difference is that typically the FDA wants 6 months of safety data to approve a vaccine. Well, we didn't have 6 months. People were dying by the drove. So the FDA said, give us 2 months of safety data and you can get emergency authorization. And that's what happened. We're about to get that 6 month data is in. It's about to get full approval probably this week. Other people say, I've had COVID, I have natural immunity. We know that people get reinfected. We know if someone with natural immunity gets a vaccine, they're much less likely to get reinfected with COVID-19. Other people don't feel like they're at risk because they're in good health. I get that. But again, I'm in this world treating patients. You can be in good health and this disease can bring you to your knees. What about if you're pregnant or breastfeeding? Well, the recommendations now are that pregnant women get vaccinated. In the beginning, it was between you and your doctor. Why? Because more and more safety data have come out in cohorts of women who are pregnant and breastfeeding, got the vaccine, no unusual safety signals were found. And in fact, the risk of complications for women that are vaccinated is lower for unvaccinated women. There's a much greater risk of maternal complications and infant complications in unvaccinated women. And again, this is not anything new. There's vaccine hesitancy that goes back for hundreds of years. The first vaccine was using Jenner's cowpox to prevent smallpox. George Washington actually mandated smallpox vaccination for revolutionary troops. Why? Because the British were largely vaccinated. We were losing a lot of fighting men to smallpox until George Washington made the decision to mandate vaccination so we would have more people ready to fight against the British. Also, Britain passed the Vaccination Act in 1853, making infant smallpox vaccination compulsory. What about polio vaccine? We have this romantic notion that when polio vaccine came out, it was immediately embraced. It was not. Even though children were being paralyzed, ending up in iron lungs, and left with permanent neurologic deficits. It took about 3 years for the United States to fully embrace polio vaccination on a wide-scale basis. Here's an example of that, Elvis Presley getting his polio vaccine. So I mentioned before, how do vaccines work? Through different mechanisms, you're presenting viral proteins, not live virus. You're not giving people COVID with vaccines. It's really it's a novel technique. Messenger RNA technology has been in development for 10 years. It was ready to go because of its rapid evolution and development and the ability to very quickly create vaccines using this methodology. But again, we've got hundreds of millions of people that have already been vaccinated with this over the last year with excellent results. These vaccines are given in a two-step process. Why? We know that when you give one vaccine, you get a certain level of immunity. When you do a booster, a few weeks later or a month or two later, you get better immunity. This is not a new or novel concept. We do it for the new shingles vaccine. We do it for the Gardasil vaccines for human papillomavirus. It's done with the shingles vaccine. So this is a way to get better effectiveness out of vaccines when you give a booster dose. Now we're actually talking about doing boosters, a third dose of booster for older people or people more vulnerable. If we have patients that are liver transplant, kidney transplant patients, they get a booster vaccine because we know they have a lower rate of responding to the vaccines because of their immunosuppression, the medication they're taking to prevent rejection of their organs. So, and I can also tell you from my experience, when we measure antibody levels in patients that got the one-step Johnson & Johnson vaccine, they're typically dramatically lower than people that have had either the Pfizer or the Moderna vaccine. And actually, the way it's going to play out with Johnson & Johnson, next month they're going to be presenting data on a 30,000 patient study using a booster of Johnson & Johnson, and they're going to probably be as effective as the Pfizer and the Moderna vaccines. Because most people are going to say, do I want to choose a 70% effective vaccine or a 95% effective? Most people are going to pick the 95%. So Johnson & Johnson realized that, so they immediately commissioned the two-step process, the two-step study. What about the Delta variant? We know from data coming out of Israel that the effectiveness dropped in terms of preventing infection, not disease, but it went from 94% to 64% because of the Delta surge. But when you look for protection from severe infection, it only went from 97 to 94%. Again, that's what we're seeing in our practice too. Yes, are we seeing older people getting infected? Yes. Are they ending up on a ventilator? No. And again, in our outpatient unit, we've treated 169 patients between July 7th and this weekend, and 50 of them had been fully vaccinated. But again, none of those 50 people have died. Only 2 of them ended up in the hospital. And we have had other unvaccinated patients many of them end up in the hospital, and several of them die. What about side effects? The most common side effect from these vaccines are a sore arm. 70% of people get a sore arm for a day or two after the first vaccine. After the second vaccine, about 50% of people get a day or two of flu-like symptoms, headache, muscle pain, feeling logy, fatigue, but severe side effects are rare. They really are rare. That said, people that get the vaccines that don't get that reactivity, that don't feel sick for a day or two, doesn't mean their vaccine didn't work. They just didn't get those side effects. So what about rare complications? The Johnson & Johnson vaccine was put on temporary hold because of a quirky, rare complication predominantly occurring in women where they would produce antibodies against platelets. So they would get platelet aggregation. They would get these unusual and rare types of thrombosis, of blood clots. And so when you look at the rate for women in age 30 to 39, 12.4 per million, so about a little more than 1 out of 100,000. But overall, the risk is 3 out of a million. So again, would I recommend a Johnson & Johnson vaccine to a woman under the age of 50? It would make no sense to do that, but I would choose one of the other vaccines. What about myocarditis or pericarditis? Again, there's a very robust system in place to look for adverse reactions from vaccines. That's how this was picked up. It was found there was a slightly higher rate of inflammation of the heart, inflammation of the pericardium in young men who received the messenger RNA vaccine, either Pfizer or Moderna. This was not like the blood clots that you were seeing with the J&J vaccine in women. It was typically a mild disease, pleuritic pain, got better with ibuprofen, Motrin, or naproxen, every now and then a Medrol dose pack, but not a fatal disease, not a serious disease. Conversely, when you look at people that get COVID-19, a significant proportion of them develop muscle inflammation, heart muscle inflammation as well. So again, risk of this rare complication is far outweighed compared to people that actually get COVID. And I mentioned before that the CDC has recommended that pregnant women receive the vaccine. So pregnant women don't just protect themselves, they protect their unborn infant by getting the vaccine. Those antibodies are transmitted through the placenta, or pass through the placenta to the infant and stick around for about 6 months in children born to women that have had the vaccine. And so again, it's not only protecting pregnant women, it protects their unborn infant. What about treatment? So if somebody is sick enough to get into to end up in the hospital with COVID, they typically will get an intravenous medication called remdesivir, and that has been shown to lessen the duration of hospitalization, because a lot of people that get COVID, they're not in the hospital for 2 or 3 days, they may be in there for 2 or 3 weeks. So if you can shorten their hospitalization, it's a good thing. There's also a trend towards improved survival in people that get remdesivir. The challenge is this: remdesivir is an antiviral. It works best when you treat people early, and unfortunately a lot of people that end up in the hospital with COVID have already entered the second phase of the illness, where inflammation is really the predominant problem, and so an antiviral medication has limited activity. Monoclonal antibody cocktails, we use these before hospitalization. We try to studies have shown that if you can identify people with COVID-19 that are at risk of hospitalization and death and treat them with 1 course of a monoclonal antibody, then you lower their risk of hospitalization and death by about 80%. So again, it's probably the most effective therapy we have, and yet it's underutilized. Corticosteroids are life-saving in the case of COVID-19. When we see people in our monoclonal antibody clinic that are in that 7 to 10 day window, very often what we're really giving them to benefit them is we're giving them intravenous dexamethasone, and we're giving them corticosteroids to reduce that inflammation that goes along with COVID-19. Blood thinners, we typically, on the outpatient world, put people on baby aspirin. If people are sick enough to be in the hospital, they're going to get heparin as a blood thinner because of the much higher rate of blood clots in people that have COVID-19. Supplemental oxygen is crucial. This is life-saving for people, and running out of oxygen, like what happened in India, is a disaster. What about ventilators? In the early days of the pandemic, people would come in the hospital with these super low oxygen levels, and they would look at them and go, oh my gosh, this person needs to be on a ventilator. But they don't do that anymore. The only people that end up on a ventilator are people who have failed low flow O2, they failed high flow oxygen, they failed pressure support oxygen. If all of that doesn't work, then they go on a ventilator. Otherwise, they die. That's the bottom line. So the only people going on ventilators are given that choice. Do you want to switch to hospice care, or do you want to go on a ventilator? The only good news is, because this is not good news, in a sense it is, young people that end up on a ventilator have a much better survival rate than somebody who's 85 years old. So more people are surviving who do end up on a ventilator nowadays compared to a year ago. But even those people, if they survive, don't come out of the hospital and go back to playing soccer. They're in a rehab, they've lost 20 pounds of muscle. A lot of them have neurocognitive deficits that take weeks and weeks to recover. ECMO is extracorporeal membrane oxygenation. It's like a heart-lung machine when you're doing a bypass operation, but you can do ECMO for people that are on a ventilator, that are on maximal support with the ventilator as kind of a last-ditch effort. This is typically used just for people like in their 30s or 40s, where you just hate to see them die and you want to pull out all the stops and try to save them, doing whatever you can. And finally, there are a couple different monoclonal antibodies that do reduce inflammation that have been shown to improve survival in these desperately ill people in the ICU. I mentioned this before, monoclonal antibody treatment is very effective for people if you identify them soon enough and get them in. So in our monoclonal antibody clinic, like on Friday we treated 14 patients, it's a full day event. Saturday we treated 8 or 9 patients Saturday morning. We're treating patients, my team is treating patients as we're here doing this talk. So it's something we do every day. And again, we try to get people in early. And a lot of the people we're treating are really sick. Some of them aren't. Sometimes we'll see people 75 years old, they've got COVID, they had their vaccine. We're treating them just as a safety measure, as a security blanket. But other people that are 40 years old, 50 years old, are about as miserable and as sick as you'd ever want to be in your life. And a lot of those people, I think, we're preventing their decompensation and their eventual hospitalization through early administration of monoclonal antibodies. What about booster? I kind of mentioned this. We're already giving boosters to people who are severely immunocompromised. Transplant, immunosuppressive medication for rheumatoid arthritis. There's a whole category of people we're giving boosters. As of next month, we're going to start giving boosters to people that are elderly that had their first vaccination in January, February, and March. 8 months after that first vaccine, they're going to start getting boosters. Why? Primarily because of this Delta surge. We are seeing, again, infections in people who, despite being fully vaccinated, are still getting COVID. So we don't want to, by boosting their levels of antibodies, we're hoping to interrupt the transmission of virus in our communities and around the world.